So let me start from here. What Divya presented, and this is the patient which we got, young boy. I remember it was one of our consultant who was taking care in medicine department, and he had an emergency at home, and I was also going to drop somebody at the railway station when I got this message, and we immediately came in the night. And this is what we saw in the CT scan. We had a massive pulmonary embolism, both at the level of main pulmonary artery into each branch arteries and further down into segmental arteries. Now, what we did, and we also did a venous Doppler, and what we found that there was an IVC thrombus, and there was also a thrombus in the deep veins. Now, the discussion was made with the heart team and the surgeon as pulmonary embolectomy was considered. However, the surgeons turned it down at that point of time, and it was decided that since he was in severe shock and severe metabolic acidosis, a thrombectomy followed by catheter-directed thrombolytic therapy would be a safe option for him. So first thing, what we did was to put a temporary filter in the IVC because of the clot, and the argument was that it could be made that the filter was not indicated, but in this setting, we didn't want any further embolization, which could have actually tilted the balance and filtration right there. If you see the literature, the filters would have only class 2A indication, and that too in this setting. They do more harm if left for a longer time, and then they should be retrieved as early as the job is done. So now this is the angiogram. If you see what we did, we got a multi-purpose catheter into the main pulmonary artery and did a selective angiogram. You can see huge chunks of in the right and left main pulmonary arteries, and there is almost nothing flowing down on the right inferior and the right upper, middle, and lower lobe pulmonary arteries. This is the left pulmonary angiogram. You can see the lingual lobe artery is almost choked with clot. The upper lobe as well as the left lobe is choked with the clot. And if you see here, this is, we had only two options here. The patient is coding the heavy inotropes, the patient is hypoxemic and hypotension. We have something to establish integrate. The first thing which we did was take a small wire, macerate the clot so that we can establish integrate flow. This is what we always do, and we have developed the strongest pulmonary thrombectomy and catheter-directed thrombolytic therapy program in the whole of North India. And after we do this, we go to each segmental pulmonary artery to do this. And the second, we go ahead. Can you mute the mic, all of the participants and the panelists? So then we go ahead and actually aspirate the clot from each segmental pulmonary arteries. You can see that happening on the right side as well as the left side. And after that, we do an angiogram. What we see that we did establish some antegrade flow. Now we can see some blood flowing in the right inferior lobe pulmonary artery, and in the superior pulmonary artery, actually you can see brisk flow. So we have reduced the clot burden and also pushed this clot a little distally. With the help of maceration, we have also increased the surface area so that now we can inject, lytic therapy, which will act more fast and more selectively in these arteries. You can see these big chunks which are treated by a catheter aspiration by the same catheter. And then after we did enough of catheter aspiration, we passed in 4 French multi-purpose catheters and we drilled multiple side holes into this catheter. And these were multiple holes because then they can perfuse the main right and left main pulmonary artery and also the segmental arteries where the clot burden was maximum. You can see while we are injecting through these catheters, these pulmonary arteries are filling up and we know where exactly to give the drug. On the right side, what you see is that, after we have placed these catheters, we put these patients on tissue plasminogen activator, and this is continued at 2 milligrams per kg per hour. And these catheters, the second slide shows you the course of the catheter, which goes through the IVC Post-catheter-directed thrombolytic therapy, which was continued for almost 20 hours, while the patient was stabilized much earlier, but we wanted to get rid of the entire clot. We also started the patient on low molecular weight heparin. He was ventilated immediately after the procedure as he became a little more breathless, and he was managed in the CCU with intensive nephrology support as he was anuric, and he was supported by 2 inotropes at this point. Then, following this, the acidosis improved and he had some urine output. We did a recheck angiogram on the next day, which revealed the PA pressures have come down to normal. The pulmonary flow has improved. As you can see, the brisk flow in both pulmonary arteries, and the injection actualized was continued for more time because we can still see some clots there. If you go by what is recommended in acute phase, this therapy has a class 1 indication, especially if the surgical thrombectomy is contraindicated. And once we did that, after about 20 hours, the patient's PA pressures were normal and he was in normal oxygenation without oxygen. His pressures, the blood pressure was also stabilized. And soon he recovered from his renal issues. We did a thrombophilia screening, as Dr. Khanna was asking. We did a protein C, protein S, factor 5, leading, antithrombin 3, cardiolipin antibodies, antiphospholipid antibodies, homocysteine levels, MTHFR mutation, and JAK2 mutation. And what we find in most of our patients, the most common mutations which we find are MTHFR mutation, which is methylene tetrahydrofolate resistance mutation, and hyperhomocystinemia. These are the most common things which you find in our Indian population. So, after on the 6th February, which was the second day, the patient continued to improve. He was dialyzed up to 7 days in the worsening of because of worsening of renal failure, which was aggravated by the injection of contrast and hypertension. Now, we put this patient on long-term anticoagulation. He was switched from heparin, low molecular weight heparin, to epinephrine 150 milligrams twice daily. And after his renal functions improved, he was doing pretty well in follow-up. And what we found in this patient is that the homocysteine levels were very high. He had protein C and protein S deficiency, and all other screening, screening parameters were negative. So after some time, when the patient was fine, after about a month, we removed the IBC filter by taking a jugular approach. You can see the filter being taken out. We did note some residual thrombus at the level of the renal vein, which was confirmed by the CT venography, which was likely because of the filter. So after that, this patient has been followed up for about more than a year now. And in conclusion, in a young patient presenting with unexplained hypotension, we should consider pulmonary embolism as a very important differential diagnosis. And we have many cases of data who are actually also in emergency where the lives have been saved, just because we have a proactive to look for pulmonary embolism and treat them straight away. This bedside echo in emergency department can provide a clue if you are unsure, and this is a very important tool in our emergency department. NOACs have proven to be as effective as VK in pulmonary embolism and PVT. And the use of IBC filter need to be reevaluated based on the patient's need and as per the guidelines. And if IBC filters are used, they should be retrieved as early as possible because they are nidus for future thrombus formation. So I'll end my talk here, and then we have another presentation on different thrombosis, and probably we can take the questions together. And I would also like to invite all of you to log in tomorrow because we have Dr. Farid Murad, who is a Nobel laureate in medicine. He is the founder, he's the one who discovered nitric oxide and subsequently endothelial functions, which came up in a big way for treating not only cardiovascular disease, but also erectile dysfunction and maybe neuro dysfunction. And he would be speaking tomorrow and giving a guest lecture tomorrow. So all of you should log in tomorrow. The time he's going to be speaking is from 8 to 9 p.m. And just to remind, we had Dr. Edstone, who released a book in the TCD meeting. Tomorrow and day after, we have a very terrific program. We have Dr. Frank Reed, who will be speaking, and also we have a man And all the proceeding of this would be published in the Journal of the Indian College of Cardiology. So if the panelists and the chairpersons allow, we can go to the next part, which is the PVT case, and then take the questions together as they are related.